The Center for Disease Control and Prevention defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. African American adults experience many health disparities in comparison to white adults. Specifically, African American women have heightened rates of maternal mortality, HIV, breast cancer, and numerous other diseases and illnesses. As I am nowhere close to an expert on the subject of health disparities, we are going to consult Dr. Lelia Noel on her research, specifically regarding breast cancer in African American women and community-based intervention programs to reduce the barriers to delivery and receipt of quality cancer services.
Really strong therapeutic ways of treating breast cancer. And nationally, overall, a woman has a 90% chance of surviving a breast cancer diagnosis these days. However, depending on where you live and your racial and ethnic makeup, that is very different. Right. So, an African American woman actually has a survival rate of 77% versus 90%. And really, what I look at is even the disparity between if an African American woman and a white woman is diagnosed with very similar tumor types, like stage and progression, an African American woman has a 42% greater chance of dying from that same tumor than the white woman does. And depending on where she lives, it can be even different. Like in Chicago, it's a 68% greater chance. In a place like Houston, where the number one cancer center is, the woman has a 70% greater chance of dying from her tumor right outside the doors of MD Anderson Cancer Center. So I was very interested in trying to figure out what is it about, what is the disconnect between these wonderful therapeutic interactions that or therapies that we have, and then getting it out to the community. And so I look at community level variables and barriers to treatment. And what I interviewed a lot of women, qualitative interviews with a lot of women, and the research that I've been presenting, at least as of late, there's two different projects. One is where I interviewed 96 African American women in North City, St. Louis, which is in and around the Ferguson area, about their experiences getting care for their tumors. And then the second was my dissertation work, which was an in-depth look at 8 women who delayed treatment for more than 2 years to find out what was going on. And so some of the things that we talk about is beyond what you would normally hear, like fear or insurance. A lot of people, when I present, a lot of people think, isn't it a problem with insurance or fear? So what I'm hearing more is that it's a little bit more involved than that, and people are more concerned about some things like how do they continue to have the stability in their home that they're so proud that they've been able to develop for, with all the violence that's going on around them. If they're too sick to care for their home and their children, then who's going to do it?
Kenneth Hardy defines racial oppression as a traumatic form of interpersonal violence which lacerates the spirit, scars the soul, and punctures the psyche. Chronic stress produced by racial trauma and discrimination puts the body into overdrive. This stress-induced wear and tear on the body can cause a lot of different health vulnerabilities, including pregnancy and childbirth complications and, in far too many cases, infant and maternal mortality in African American women. Let's see if there's a link between racial trauma and breast cancer in African American women. Racial trauma and the effect that has on women. So do you see this effect in the women that you've worked with?
Yes, exactly. It's definitely the racial trauma, I guess, is what I am calling, what I was trying to describe as sort of like the stability of their home, kind of like like they've worked so hard for so long to keep some of that out of the home, that if they're too sick to care for themselves, then they feel like there's nobody that's going to be there to keep it out.
Right.
And they've lived with racial trauma for so long, their whole lives basically, right? Their whole lives, that it's not something that they can see, that they can just walk away and their house is going to be okay. So that is exactly why I believe that we see some of the disparity that we see in the mortality rate between ethnicities. But it's the idea that they know they're giving birth to a child of color who's going to have to face racial discrimination, and that stress is a constant thought. How am I going to protect my child? What am I going to put in place? Also having to deal with daily microaggressions at work
Right.
or schools or wherever they are. But the big that can then be community-based interventions or clinic-based interventions that can put some things in place that increases communication between the community and the healthcare system, so that it builds trust, it builds knowledge about what's available and access to those resources. It would be partnering with that church to do community events, or maybe holding some sort of health fairs or something like that.
Right.
Because you're putting a stamp of approval on that person at that point, and the community might pay attention and be like, oh, I didn't know that was available to me. And so really finding that key informant within the community where people actually will hear it and trust, that's going to be important.
Right. So do you think that there's a way that social workers and people who are involved in social services can partner with people within the community? Okay.
I think that's a key role for social services. I think that is where we shine, is that we make wonderful bridges between different entities like the medical community and communities of color, and also isolated rural communities, because we have, as health social workers at least, we have one foot in each door.
Right.
And so we know the language, we know what's needed from a medical perspective, but we also understand the needs of the community and how they need to receive the information in order to be as responsive as possible, and also for it to be a sustainable intervention as well.
To ask more generally, have you specifically just focused on breast cancer, or do you look more generally at other health disparities as well?
That's a very good question. So I actually look more generally at access to care, access to treatment for vulnerable populations. For example, I recently worked on a project also in St. Louis on why we see such high readmission rates through the ER for certain populations. And we did a qualitative study where I went into the homes and interviewed people who were lung or heart patients who had been released from the emergency room setup, regardless of whether it's breast cancer we're talking about, or prostate cancer and colon cancer with communities with men, or if we're talking about heart patients and lung patients and ER visits. I think that it's a similar issue, that we can't rely on the healthcare system in and of itself to be the vehicle of getting the information out to the community. It needs to be some intermediate that's able to speak the language of the community.
Right. Is there any type of link between, is there a higher rate in diagnosis of breast cancer among African American women? Or are the rates the same, but the treatment is just very different?
Excellent question. You're doing really good with your questions.
Thank you.
Yes. Okay. As a matter of fact, African American women are diagnosed at a slightly higher rate than white women. So it's like 72% for white women and 73% for black women. So the diagnosis is there, and they're getting screened. The screening rate, the mammography rate is high. So they're getting screened and they're being diagnosed, but it's the treatment part, it's getting them into care where we see the most delay.
Do you think that that is kind of a failure of the healthcare system, and that we can't rely on them to be the ones to reach out? Like, for example, in an ideal world, they would be able to reach out to these communities, or do you think just more generally it's better to have someone within the community as a resource?
So I don't know that I would term it a failure. It's a very good question. Again, I'm not sure if I would term it a failure of the medical community, because again, I think that they come from a really good place where they want to help and make a difference, but their training is completely and totally focused around diagnoses and treatment. So also, I think if we flip it and think about communities, regardless of what community it is, right? If we think about communities, it's always best to have a champion from within the community, right? So even though, no matter what community it is, I think as a medical profession, you still would want to partner with
Right.
someone from within the community to be your guide in that community.